Session. I have the pleasure and the honor to welcome to this panel the representatives of the political sector. They are the ones who decide about us and for us. They are Mr. Vasilis Kondozamanis, Deputy Minister of Health, Mr. Petros Michail Papas, MP, Syriza, Doctor, and Rosa Vretou, Doctor, Deputy Secretary for Health Sector, PASOK Kinal. And I would like to put to them a question, which is actually the topic of the conference. We have a changing environment. Are we ready to operate in such an environment? Are we ready to deal with all the challenges and difficulties that emerge in the health sector? I would like to start with Mr. Vartzopoulos, Deputy Minister, Ministry of Health. Mr. Minister, how do you see all these changes? Yesterday, with Professor Mosialos, we talked about multi-crisis, about the migration flows, about conflict, the climate change, all of which have an impact on the cost of living. So how can we possibly manage all these major challenges and the impact they have on the health sector? First of all, Professor, I would like to say that I'm not that pessimistic about the future. Because if we take a look at what has happened in the past, we will see that every decade that goes by, and regardless of the problems that may have emerged, is better than the previous one. Of course, we can say that today we are not better than we were 50 years ago, and the possibilities of someone dying from a stroke the possibility is greater than being killed in the context of a war. So the world is improving, but at the same time, the demands of the citizens are increasing. The demands are increasing. We have a life expectancy that is unprecedented in the history of humanity, 82 years. The day before yesterday, I was watching a film about Napoleon, who died at the age of 51, and back then they thought that he was old. So the demands are increasing, and this is for the better. How can we deal with all this? In every science, we should have an evidence-based approach. We need to use best practices and optimum example. Even when we cannot have quantifiable measurements, we have the best practices, or we have the best results. There is a past experience that actually shows the way we need to follow. Look, and maybe you know it better than I do. Both theoretically but also practically, there are 6 systems in the world. The one that is of an anarchist nature, and the 2 rest are the 2 ordered systems, the Anglo-Saxon one and the Central European one, that have different approaches, of course. Our system is a copy of the British one. This is my view, okay? The system that proved that it is more successful for the citizens is the Central European one. The differences are substantial. The differences are great, especially when it comes to the way all the systems are assessed. These 2 systems are assessed. The one system operates in a way that is based on the civil servants offering services for free, and the other system is operating on the basis of the rationale that the services need to be offered for free, but at the same time, there is an assessment of the services on the basis of their performance. And what we are trying to do, and I would like to close this first comment, is that our system is a system that was created 40 years ago, copying the Anglo-Saxon one. But what we need to do now, given that there is this good practice coming from Central Europe, What we are trying to do now is to adopt not only all the system, but some parts of it. Unfortunately, we're not trying to copy all the system, but only parts of it. And I mean that in two ways. The first, the freedom of the doctors to exercise privately, that is both inside and outside the hospital. Outside the hospital is not that common. We allowed the private practice recently, and then the introduction of DRGs, that has given us the opportunity to have a clear picture of the effectiveness, not only of the hospital, but also of specific sectors that may lead to decisions about the staff that is employed there. And I would like to say a few words about two other sectors. The first is the sector of mental health, where we are trying to make a significant reform, again, copying the European standards and networks of services that are interoperable and that combine different entities. And the other sector is a sector that will be of interest to many, including you, Mr. Professor. And what is that sector? The sector of long-term care. Long-term nursing care, which is a very demanding sector, actually, since it constitutes an important subsector that is clearly associated with the life of the patients. And if the Greek household has one thing to be afraid of, this shouldn't be the expenditure of the health sector. A big operation can be performed in any hospital of the national health system. Otherwise, AOP will cover the cost to travel abroad. So what is burden for the Greek household is the care of chronic patients or of the elderly. You have a patient with a serious problem with mobility that you need to take care of. And that is why I say that this will be of interest to us in the future. And that's why we need to focus on that. And that's why we are preparing a legislative initiative that we will soon present to the Parliament. Yes, thank you.
Yes, indeed. Thank you very much. The life quality and the life standards increase per decade, but there is, of course, fluctuations in human history. But if we look at it macroscopically, there is indeed some progress. And this progress makes the right to health more important and something we claim. There is, of course, fragmentation in mental health. There's a lot of structures, well, with not dubious results, but maybe with outcomes of that are not there. And we need to do some housekeeping there to see some results. Now, regarding the, if I may offer some comments, some expenses were destructive due to the time. We pay 35% out of pocket for health services. They're not all the choice of those who have the money can fork out the money. In some instances, it's the only choice because there's no luxury of time. But I will agree on these informal forms of support or the care of the elderly, because it's an atypical economy there. We don't have caregivers. We have caregivers who do this through atypical payments. And of course, we don't have sufficient areas of places that can actually offer this study. We did some studies there for atrophy there because they have problems with raising their children and they do not have the coverage there, the spinal muscular atrophy. There are problems in the family budgets that we need to focus on. Now, Mr. Kondozamanis, dear Vasilis, what did the pandemic teach us now that you no longer have this huge challenge that you had to manage on behalf of all of us? Did we learn anything? Do you see us changing the way in which we manage things as a system? Well, indeed, we did learn. We did learn a lot of things after the pandemic all these years, and particularly at the level of political counter-arguments. The opposition accused the government that everything is falling apart, everything is being demolished, and everything is negative in the health system. This pandemic showcased the positive points of the health system, which allowed us to manage it successfully, but at the same time to plan things and to implement things and keep implementing them. Things that we see today were planned and designed during the pandemic, like the RRF. All these projects were designed back then. The cerebral stroke centers and so on and so forth. So what was the teaching that we received? Was that since we have a team, a strategy and a goal, you can have results, which gave us the possibility to create the appropriate, nay, necessary legacy that will allow us to move forward. And this is what we must do, and to place particular emphasis on sectors and micro levels. Because we're talking about health expenditure as a percentage of the GDP, etc., etc. We also spend a lot, and we're close to the European average, but there is no payback, you see. So at the end of the day, this means that citizens are not satisfied with the services provided, and we still have unmet citizens' needs, okay? This is also due to the fact, and this is something that Mr. Vartopoulos said, it's due to the fact that we don't have integrated post-hospital care. We don't have terminally ill patient care. There is no organized network. We have very high out-of-pocket expenditure for health, and it goes back and it circles back to the citizen, because that is the goal, how to best serve the citizens and meet their needs. Which is why we still have the unmet needs in the sector of health. There is, of course, a design, there is a plan, allow me to say, even before the electoral result. There is a continuation in this governance, but we need to look at things at the micro level. And please allow me to raise this issue and to focus on it differently. There are a couple of things that we need to see and we need to revisit. First of all, microbial resistance. There is a huge burden on the care from the infections caused due to the microbial resistance. It's the resistance of bacteria to antibiotics. And we're first from last in Europe. And of course, there will be a resolution regarding the actions that need to be undertaken by all states to actually deal with this phenomenon at the level of European Authority for the Preparedness regarding health centers, the HERA, which I represent the country in the board of directors. There are initiatives on that. And there are issues we need to revisit, like, for instance, dementia. Dementia in the wider sense, because we have Alzheimer's disease in this, but all these things have been characterized as a tsunami for health systems. And you, Kyriakos, mentioned earlier some of our fellow citizens who need help, these indirect expenses and all these things that burden the health system. So it's these issues that we need to revisit, and not just dementia. You see, Dimitris Vartopoulos talked about the networks at the level of mental health. We need to develop networks everywhere, on cardiology, on oncology. There is an ongoing effort for the vascular disease treatment centers in order to be able to deal with the challenges. Well, DRGs and everything are fine, health expenditure is fine, there have been steps forward. We don't need to reinvent the wheel. We know what's happening, we need to move these forward fast. Because I remember that DRGs back in 2014, when I was Secretary General, we went to Germany to sign the agreement on the DRGs. Today, it's 2024, and we're still talking about the implementation of the DRGs, which is impending. The Chinese say, when is the best period of time to plant a tree? Is it now or 20 years ago? It's now, because 20 years later we'll be talking about the same things again. So we need to have this strategic picture and image of what happens. But we need to see at the micro level that how to see these things. And let's not forget the developmental aspect of health. And we need not forget these relationships. Better health leads to greater economic growth. And economic growth gives the possibility for more health expenditure in order to increase the health level of health of the population. Because health has a financial dimension, and we need to see this dimension as well in the next months to come, in the period of time that's coming, so that we are able to provide the health services needed by all of our fellow citizens.
Thank you very much. The truth is that the pandemic replied to this pseudo-dilemma, health or economy, reminding us that we cannot have economic growth or social cohesion without a strong health system. And, of course, the opposite. A powerful health system requires resources that, of course, can result only from a sustainable economic environment. Just give me 30 seconds. Dimitris Vartopoulos actually made it clear once again with regard to the character of the health system. We're talking about a public health system because 9 out of 10 times in the country we tend to confuse the public health system with the state health system, where the provision of health services is done for free, and it is there that the public and the private sector meet, actually. Yes, we actually clarified the concepts. There is a misunderstanding. Half of the citizens hear public health and they think that it is the public health system, or they hear free health. What does free health mean? When you need something, when you get a service, you need to pay. Since we need to pay the doctors and the nurses, and we need to pay them even more, actually. So, at the moment of need, the cost should not constitute an obstacle. And I will agree with Mr. Vartopoulos that the Central European model fits better to a country like Greece because the freedom of choice of the point and of doctor is important in many European countries. In others, no. But we cannot possibly demand a change of mentality and mindset from all. I would also like to say that 75% of the population in our studies believes that it is absolutely necessary to make a structural reform in the health system. And it also believes that this reform is not made because of the political cost. And then we interpret that by saying that there is political cost because there is a conflict of interest, if you like, between different groups and because of the lack of political consensus. So the floor to you. Can we possibly hope that there will be a convergence of views at some points and with regard to certain matters? Because if you take a look at the programs of the political parties, you will see that they are more or less the same. For example, family doctor. We still don't have the institution of a family doctor developed. Can we hope that there will be a consensus about that and about other matters as well? Kyriakos, I believe that we need to acknowledge the fact that we start from a point that is highly problematic. We have structural problems in health in Greece. We started with a health system that is centered on hospitals, in contrast to what is the case in other countries. Here in Greece, we never had this culture of family doctor that existed in other countries. So automatically, we place a higher value on hospitals. And this, in my view, deprives us of a significant forces of primary healthcare. We started from the wrong starting point. Even from the start of the previous century, the moves made were not the right ones. And that is why the health system that was developed was not the right one. So we have a rudimentary primary healthcare after the effort that was made in the 80s with the health centers. Then in the regions, we had a satisfactory level of primary healthcare, which, of course, is not the case in the cities. Then the primary healthcare collapsed in the regions to a great degree. And we also experienced that during the pandemic. Countries that have a more effective network of primary healthcare, like Portugal, for example, operated this primary healthcare. They got patients with COVID to the primary healthcare units, and they protected the citizens who didn't have to go to the big foundations, because here we want to go to the biggest hospital that there is in the country when we are faced with a problem. Which meant, in our case, that the virus spread faster in these big hospitals, and that is why we didn't get very good results when it came to the management of COVID. So this is the structural weakness that I believe was very important. And now, with regard to the elephant in the room, the salaries of the doctors and of the nursing staff in the country. We operate in a free market, a competitive market. There is the private sector. There are the countries abroad that remunerate mainly the doctors, but also the staff very, very well, and they ensure better working conditions. And right now, we experience this tragic situation in the health system because of the brain drain, because of doctors and nurses leaving the country in order to work abroad. Of course, some moves have been made in order to solve this problem, but I don't know whether these moves are enough and whether they are cost-effective. For example, they have allowed the doctors to exercise privately, but I don't know if this is effective. Maybe we cause artificial demand in that way. Maybe we turn the private practices into the waiting room before they go to the hospital. Or maybe by doing that, we will lead the doctors to use the hospital in order to attract patients. So is this the right solution? And I'm hearing what the government says. It says, where can we possibly find the money to make increases? And okay, I understand that. This is a valid argument. I know that every government would like to give more money to the doctors in order to keep them in the system. But what we need to do is to take a look and copy the best examples that exist in Europe, and also find ways in order to make savings. Here in Greece, we have a huge artificial demand for laboratory tests, for drugs. We are the country where, okay, steps are made. I'm not going to say that we haven't done anything. We have made steps in order to make better protocols. And it is a fact that the cost of drugs, but also of laboratory tests, is huge in a country like Greece. There was a time when we were actually having the same CAT scan tests with Germany, where the population is 80 million. So what I mean by that is that we need to approach in a very sincere way this problem and try to find the right solutions. Because, okay, we may say they are going to give additional incentives, we are going to make some changes in the working hours of the doctors, but I don't believe that these will actually provide a long-term solution. Maybe they will lead to an even more increased cost. So that is why we need to see how the example of Romania, for example, has managed to succeed when it was faced with similar problems. When other poorer countries also were faced with that problem, how did they find the solution? We need to have a candid discussion about the way that nurses should be integrated in a special payroll scheme. And something else, because I don't want to take much of your time. We need to see how we are going to develop a health system that will make the most of the nursing staff. We are going to provide specialties to all nursing staff. We are going to increase the number of acts performed by the nurses, again by copying good examples from abroad, like, for example, the Swedish one, where the acts that the paramedics and the nurses perform are many. This may reduce the need of having many doctors. And of course, I could talk about the redesigning of the health map that is absolutely necessary. I could say about the drugs, about the need to ensure access to new drugs for all patients. I could talk about the greater involvement of patients associations in the choice of treatment, because the Patients Association are very powerful around the world, and that is why they have a significant role to play, and that is why we should involve them in the discussion. There are many problems that afflict the health system, and no matter what we do, we need, and just to use the words of the former Minister of Health, Mr. Papadopoulos, who tried to change the system of university doctors so they can actually exercise privately, we need to do more. We can bake eggs, we can do a lot of things, but we need to have a consensus. Thank you very much.
Right. Well, I don't think that the medical associations actually agree with this enhanced role that you said. At some time we uttered of talking about prescribing, having nurses prescribing material like gauzes or anything, and they said it's a medical act. It's nothing to prescribe gauze. Okay, this is incentives. We should give incentives. Or the enlarged and the widened role of pharmacies. So it removes vital space and everything and all that, and we need to discuss something, and I'm very happy that we have this high-level dialogue here, because this is how dialogue should be. Mrs. Vretou, dear Rosa, why are doctors leaving and moving abroad? Is it so much better? Well, they don't go to Romania that much. I should like to thank very much the organizing committee for this exceptional honor of inviting me here today. It is the last session, but I believe that it is very interesting. This last session is touching upon the most explosive things that may be implicit to some people, but to those who need these services, they are explicit. Now, if Mr. Souliotis, dear Kyriakos, you're raising the issue of human resources. Now, the Greek doctors ask for their degrees to be translated to move abroad. Greek high school graduates do not prefer nursing schools. In the immediate future of the next few months or year, the nurses we'll have in Greece will not be enough to staff the private or the public sector. So in order to say that we are optimistic, I must say that we need to have things and measures to implement, that we see the future of the health of our population in Greece optimistically in the next 10 years. This requires political consensuses, but this is definitely a question that, dear Kyriakos, is addressed to the government, and I secondarily agree to the major and lesser opposition parties. As regards the individual issues, doctors will leave Greece, and all young doctors will, but even the doctors who today are staffing the national health system, and they will leave for three reasons primarily. First of all, wages, remuneration. Second is re-education. Not a single euro from the RRF was introduced to the retraining and re-education of doctors and nurses, and they could. The main government policy was to renovate the structure, which is indeed required, but since that structurally we haven't yet decided which structures we need and where, renovation should have been step number 2 rather than 1. Well, the initial step would be to know what needs we have per region on the basis of the population's morbidity and mortality, and it's something that eludes us, not only due to the lack of political will, but also in its technocratic dimension. So there are members of staff in the Ministry of Health or the private sector who could very easily play this role, and please allow me the criticism that this health map in the country can't take that much time. When the LSE was asked by a group of specialists to study the Austrian system, which is one of the most complicated in Europe, they did so within 6 months. So consequently, there are issues that have to do with the operation of the system and, on the other hand, our own operation, both at the political level and at the technocratic level. And if I may, I would like to add another issue, that university departments that produce work And Kyriakos, the publications we've had from your department and the department of Kostas Athanasakis, whom I can see over there, show very eloquently what Greek patients pay out of pocket in order to cover their health needs, and this cannot go on forever. It's impossible for someone to pay nearly 40% of their health expenditure out of pocket. This, for a great number of households, and I work in private Athens, for many households, this is catastrophic in terms of expense. In order to reduce this, the periods in which out-of-pocket expenditure were reduced in Greece were the periods of time when the national health system had a brave increase and a lot of money. It's back in the 80s, late 80s, early 90s. I'm not saying that we should go back to that time because there were a lot of problems at that time as well. The fact that we have the DRGs in the hospitals is a very important step regarding the cost and the costing of health services. But this is not enough. On the one hand, we're lagging behind in giving incentives to the doctors and the patients, mobility, training and remuneration, wages, and we're still lagging behind in actually saying what sort of redistribution is required by the healthcare services in Greece. Thank you very much indeed. Oh, thank you, and allow me to add something, because I think that we're speaking the same language, we're on the same page. Now, Greeks express that 35% intend and are willing to pay 35% out of pocket. We are willing to pay, we're trained to pay, but 60% do. Which means that in this difference there are people who, in inverted commas, are forced to pay, to have timely access. When you have a febrile child, you can't wait for 8 hours, you will go to a private pediatrician. So we need to locate those points in the system where the big burden of the households is imperative. You cannot stop someone who's controlling the cost to choose a private structure to do a diagnostic test paying 15% on very, very low laboratory prices. Because this is it's something that people can bear. It's bearable. And this is a question to all. Can we see the supplemental role of private insurance? We need to include private insurance. Following the Central European models, not as opposed to social security, we can never do that. And if someone said so, it's perfectly all right. We cannot substitute social security, which is mandatory, with public. It's to secure the private money that is offered out of pocket and from which family planning is threatened. Because what goes hand in hand with health is insecurity and risk. So we need to put public security, public insurance. You will have a private insurance contracts that the maximum number is that the one of your contract, and you will not have any other out-of-pocket payments, and this will help with dealing with para-economy, with black economy. Mark, are we ready to say that the first 100 euros on the basis of your payment bracket are yours and then the state will pay, Mr. Suliotis, so as to ask for receipts for every transaction rather than to be complicit to this black economy game? Because you want to prove that you reached 100, 200, 300 euros and then the state to pay and say that I paid whatever it was to pay. If we want to talk about guarantees of non-catastrophic expenditure, we need an entirely different way of approaching reimbursements and expenditure. But is the Greek society ready? Or are we accustomed to everything's free and someone unknown will come in and foot the bill if we know that this unknown person does not exist? Minister?
Very simply, if we assume, based on what you said, Professor, that indeed there is a special agreement with the insurance sector to cover the private health acts performed by the doctors of the public health system inside the hospital, as is the case in Europe. You understand that this makes the public health system the most powerful and competitive employer in the country, and the 1.5 billion euros that are given to the private sector would then be given to the public one. So you understand that we would find a completely separate source for funding the national health system. And something else I would like to say, which I believe is both pleasant and optimistic. Here we have representatives of different political parties. And by the way, what I'm about to say is similar to the European experience, and that is that all the political forces can actually agree on certain basic principles and on the basic good examples. It is a fact that in Europe, the biggest change that was made after the war was made because there was an agreement among all the political forces, Christian Democrats and Social Democrats. So if we don't do the same here, we won't be getting any results. Mr. Kotosamanis, can we find a more rational funding model that will include private insurance? Previously, I said that we can actually ensure the participation of the patients. We don't have to reinvent the wheel. Others have done it before us. We only need to do copy-paste. And we need to do it now, because this is the last opportunity that the country has, and we need to seize it. We talk about the public health system, we talk about free health, but we are the third most privatized health system on the planet when it comes to health expenditure. And indeed, there is this willingness to pay on the part of the patients. Yes, not only the amount we pay, but also the willingness to pay. 1.5 billion is the turnover of the private clinics. And I believe that we can actually agree on some basic principles. If one hears Mr. Papa and doesn't know that he is an MP of Syriza, they would think that these were the words and the suggestions of someone who does not belong to the left wing. I remember in the parliament, whenever we were talking about PPPs, and by the way, PPPs are funding tools. They are not privatization measures. No, when someone hears private, they think that we are talking about privatization of the health sector. No. So if we agree on this, then we will be able to move forward. Yes, because the devil lies in the details. What we need is an institutional framework that will guarantee the fact that these PPPs will not be to the detriment of the public. So there have to be some binding rules that need to be put to the table. And these rules should be observed by the two parties. Yes, in pandemic, we used the Erikos Dinan hospital, and no fellow citizen paid in order to get the services from the Erikos Dinan hospital. So yes, we can actually use the private structures, and we need to make clear that there is no transfer of wealth when these transactions are taking place. Mr. Papas is bold enough to say these things. Mind you, he's a representative of the left. So everything he says is actually in the right direction in overcoming these obstacles. I believe that we can find some common ground. If we take aside the people and the capacities, we expect what we hear from representatives of different political parties. But this is not the case in this panel, and this is a very good thing. Mr. Papas, if I ask you to hierarchize the problems, what would you say? Do you think that the government has missed something when it comes to health because of that reason or the other? I believe, and I believe that this is related to what Mr. Vartzopoulos, the minister, said, and that is that we have a very deficient approach to disability in Greece. And this is not the problem of the present day, nor a responsibility of the current government. It is an old problem that afflicts the country. We have systematic shortages and deficiencies in how we treat the people with disability, starting with the identification of the people or the identification of structures, from the lack of housing that is a problem that the disabled people are faced with, the huge anxiety that parents feel about their children who are disabled, the fact that the hospitalization fees that are covered because of the increased cost of living is not enough. The 70 euros that are given per day are not enough. Are they more? No. So what we need to do is to have a very sincere discussion about how we will at least start having a more decent treatment of people with disabilities here in Greece. Because currently there is this chaotic approach to these people. There is this chaotic framework. I come from Salonika, and I know that the structures that exist in Salonika, the public ones at least, are very few. There is the foundation of Agios Panteleimonas that no parent wants to take the child to. And yes, we need to find ways to promote initiatives that may come from the private sector. We're not here to penalize the private sector. If the state does not have the capacity to do what is needed, then we need to find ways to involve the private sector or the families or the associations. But all this should take place in framework that is comprehensive. I believe that this is something that should be included in the reform of the health map of the country. Yes, we are about to close this discussion. You have some seconds. Yes, I would like to add something that is very important and of strategic nature, apart from AI, cybersecurity. And if one takes a look, they will see that it is one of the priorities set by von der Leyen for the coming period, cybersecurity in hospitals. Yes, but this is not just a matter of data. We are not in danger. We keep the files in the basement. So, okay, look, cybersecurity does not pertain only to data. It is a huge matter. For the time being, we have paper records, paper files, huge rooms where we keep these files. Unfortunately, the speakers speak at the same time. I feel the need to say something to Dear Rosa. Dear Rosa represents a sector that has made a lot of changes, regionalization of the system, AOP, prescription, which, however, are not enough, because when the time of reception of reforms came, a resistance emerged. But, of course, at the end of the day, they were proven right. No one today can say that the prescription was not a right step or that the privatization was not the right step or AOP. So do you believe that you have a negative stance vis-à-vis changes that in the future will prove to be very successful and beneficial?
I don't think that we're running such a risk, because a big part of the people who are working in the field of health in PASOK are either nurses or doctors or people from the finance, from health economics, which gives you the possibility to see the truth from various facets. And this multifaceted quest for the truth is what scientists are all about. And this is what PASOK is all about. And to be fair, the way in which the 1981 SC, National Health System reform, was built and how the system was built by 1989, it was not on empirical data. It was built on the first data from the health economists that were available at the time in Greece. So subsequently, all the reforms that were instituted by PASOK, including those who came in as collateral benefits from the memorandum, I'm talking about e-prescription that should have happened earlier, and AOP. The unification of the funds should have occurred at least 10 years earlier, were very nodal and key issues for this health system. Now, I have an objection with the mere copying of systems from Central or Northern Europe. The structural problems of the system have some very Greek features, and it is the reason why they cannot be resolved from solutions that come from Denmark or Germany or wherever. The committees of our own people, and we have such people, we need to elaborate and to process solutions that will best fit the problems produced here in the country. This is one of my substantial objections in copying systems from other countries. Regarding private insurance and its mandatory character or not, I think that people's insecurity as regards health-related issues stem rather from two subjects. A, the cost that any health problem will have for the patient, and the second, it's an inherent problem of our system. It's the quality of the services offered. We will definitely have to move forward in how we regulate the services rendered, be they from the public sector or the private one. We must also regulate the private insurance market. In the Netherlands, where the system works with private insurance companies purely, same in Switzerland. They don't have what we have. There is the taxation in the cantons that finances the health system, and there is the mandatory character of private insurance, but it's an insurance that insures you regardless of your funds, of your resources, of your money. So there's a lot of issues that we need to see before we say, well, yes, let's burden each household or someone with an additional mandatory private insurance apart from the mandatory social security. Thank you very much for the response. It's not an additional burden when you already pay 5 billion out of pocket. It's a reduction of the burden. Now they're under a huge burden. We believe that if you insure this, the prices will drop. Because if something is insured, it has lower prices than it's in the free market. And then serious countries come in, like the ones from Central Europe, say that some companies will not insure the elderly or people with a bad history. They have a fund, all insurance companies, and they give bonuses to those who insure those people. So there are always answers in organized countries where they see the problem and they have the ease to legislate. Yes, well, there are solutions, everywhere. And we're not talking about a sterile copy. Always an adaptation will be necessary for the peculiarities and particularities of Greece. Mr. Themistokleou said that we are a highly insular country. There's no other country. I mean, I can't imagine a hospital not existing in Chios because it's not efficient or effective. We need to have a hospital there. Now, it might sound that in this way we will institute or legislate an inequality. And the solution to this is possibly how to ensure that, well, let's say, that we accept that there is private insurance that is mandatory. How can we ensure? No, not mandatory, as a compensation to the willingness to pay out of pocket. Yes, well, how will we ensure equality? The people who are financially weak, there is no equality in out-of-pocket payment. Yes, I agree with that, but maybe what Rosa said, that by copying or by adopting practices of Switzerland that has as a mandatory pillar private insurance, but at the same time the private insurance secures and safeguards and access to those who are financially vulnerable, is a more fair system for which we should be fighting for. Now, the financially vulnerable must be protected by the system without additional out-of-pocket payments. What I'm saying is, and my idea is, that this plethora of private money that is paid here without uncontrollably needs to have a cap. And I close with an ascertainment, or rather with a finding. 1980, 15,000 hospital beds in the non-for-profit or social hospitals. Now, out of 15,000, we went to 35,000, 40% in 80, 40% in 2000 with some fluctuations. It is an established out-of-pocket payment. And for some of our fellow citizens, it's unbearable. We need to organize it and limit it and curtail it. And I can't think of any other way. Even if we increased public expenditure by 1 or 1.5 billion, I don't believe that the out-of-pocket payments will be limited, because it's a payment that has the cost time or cost money. Will you wait or will you pay? Will you choose your doctor or will you go for free? Because the Swedish system, for instance, does not have a freedom of choice. You go to the doctor who happens to be on call at the time. And you can't say he's not my doctor because he was selected by the system and he becomes your doctor. So such an adaptation, I will agree, must happen in the Greek system. Each system has its pros and cons. Let's see which model is good for us with the adaptations that we must make. But I believe that the British system, with a GP who comes, GP with special interest, the specialization is not what we're missing now. Without this meaning that we shouldn't have a point of reference for the access to health systems. I would like to close and conclude the conference with the conclusion of this table, because I was given this role. Please allow me to be the director here, and I will say that the question is, in this changing environment, whether we're ready. I see a first-class cross-party committee for the discussion for two reasons. First, for the substance of the arguments, for the documentation of the arguments, and for the very civilized dialogue we've had. It is this dialogue that we want. I'm talking as a citizen. We as academics, as university professors can say whatever we want, but this is the level of dialogue and debate we want, with arguments. We heard different opinions, and some opinions that appear somewhat convergent. I would like you, in the things that you agree, to move things forward and to dig deeper in what you disagree. Now, truth be told, we may provide documentation and proposals. The actors, the patient representatives, or the business representative may come to the table of dialogue with proposals, but those who will make it happen are our representatives in the parliament and in the parties. So I would say that a cross-party, all parties, committee of scientists, and I believe that this level came from the background of each of you, okay? You're all scientists. Apart from your positions of responsibility, the background is important. We have people who are living in the health system from different aspects and sides. I want to thank you so very much for this, because we're leaving with a note of optimism, and the answer to whether we're ready is not a yes or no. It's, well, we may not be ready today, but we're not that far from it. Thank you very much, and thank you all very much as well for these 2 very constructive and creative days.